Sorry, everyone. The mic was a bit high for me, but hello. Hi, I'm Stephanie Cho. Welcome everyone. Thank you for being here. We are going to be talking today about the new, well, I guess not so new anymore, the most recent updates to E&M coding, and in particular, sort of how it applies and impacts CL psychiatry. And a very clear plug that this was brought to you by the Business of CL Psychiatry Subcommittee, as well as the CL Division Directors SIG. So, why this workshop? Kind of three main points. Number one is that professional fee coding, also known as billing, is important. Yay. But then second is that many of us don't feel confident with our coding skills. Third is that there were some changes this year that do significantly impact us as CL psychiatrists. And so as a group, we're wanting to try to dig a little bit more into it in a more sort of high yield fashion for all of us. The first thing though is again, why is it important? So billing and coding is actually very important for healthcare equity. Billing brings in claims, brings in reimbursement and money. Now, even though we kind of have a larger issue to contend with, which is that reimbursement structures undervalue psychiatric care, within the structure of what we have, we need to do our best. And being proficient in coding, being accurate in coding, allows us to get the best reimbursement that we can, be able to accurately reflect our productivity, and then in that way be able to maintain the current services we have and potentially expand. And so really understanding business of CL psychiatry is enabling access to care. This is particularly important in areas that are underserved, in community and rural settings. And so the first thing you think of is, well, this is a kind of service line or division issue. And it is, because coding brings in revenue, again, which allows for financial sustainability, and it allows for as competitive of compensation as you can provide for your team. The second is value and productivity. It's a way to show what value your service is bringing, what value your service is adding, and it's also a way, when needed, to justify the resources you do have. The last is kind of a more exciting one, which is that it can help you make the case for expansion or for increasing resources when you grow or as your community requires more resources. Beyond that, though, it really actually comes down to the individual CL psychiatrists. Individually, it's important to code because, especially maybe if you're RVU or productivity based, how well you're coding, how well you're billing will actually impact your income. It can impact the salary, and if you're in a bonus structure, it can help you gain financial bonuses. It's also a way to reflect your productivity and your performance, especially if there are specific work effort expectations that you have in your job. And if nothing else, it's a way to get credit for the work you are doing. Lastly, it's a way to support and strengthen your service that actually provides for job security. If you're able to demonstrate that, you and your team, your position is necessary, is productive, that provides for some job security. And again, as we talked about before, it helps to ensure and increase access. So again, the problem is we don't feel comfortable with it. And, now it's 3 years ago. 3 years ago, the CL Directors Division did a survey. And the survey showed that even though CL directors really do highly prioritize demonstrating their services value, fee coding, which is kind of a very quantitative way to do it, was one of the lowest rated areas of confidence. And this is not just limited to faculty and division directors, trainees, and early career physicians also very clearly report recognizing the importance of fee coding, of billing, to being in an effective clinical practice. But in their training, they feel that they have gotten really insufficient education on how to do it. So I'm just going to do kind of a quick overview of sort of the basics, because it's a little bit of an alphabet soup, right? Like RVU, CPT, E&M, right? What are these things? So CPT stands for the Current Procedural Terminology. It's a manual like this big, maybe bigger, and it's put together by the AMA. The purpose of it is that it's a standardized coding system for medical services and procedures that we as physicians provide. It is standardized. It is essentially kind of the one system that we use in the US. And so what does it provide? Why does it exist? It exists to give us nomenclature, to give us very clear kind of like literally codes, right, for tracking population level healthcare. So, CPT codes are not just used for billing, which is, the next bullet on the slide, right? But it also helps provide healthcare data on utilization, on types of services provided. And how does it do that? There is, for every billable clinical activity, and actually for many non-billable clinical activities, there is a CPT code that applies and that describes what the service was. That code is then submitted by you or your hospital systems to whichever insurers or payers that there are, to end up creating a payment claim and eventually, hopefully, get some reimbursement. Now, how does that reimbursement happen? So that is related to something called the Resource-Based Relative Value Scale, RBRVS, which I actually think maybe just the whole name's easier to say, but this scale is actually used by CMS, the Centers for Medicare and Medicaid Services. And as CMS goes, pretty much everyone else goes. So most other payers as well. And what this is it's a physician payment system. And this system was created to base payments to physicians and to systems based on the resources that it takes to provide the service. And so what does that mean? So there's this thing called RVUs. I think probably most of the people in this room have heard about it at this point, maybe bane of our existences, but RVU is relative value unit. And the total RVU is actually comprised of three parts. One is practice expense, like having the overhead of the building, of the clinic space, right? The second is malpractice expense. So the malpractice coverage that you or a hospital needs to maintain. And then the majority of it really is physician work, which also is called like WRVUs, work RVUs. And that is how much training, physician time, physician effort goes into providing the services. The physician work RVU also is essentially what many hospital systems will use as a quantitative marker of individual physicians' productivity. So there may be expectations of you will do 4,000 RVU in a year. That's an expectation. If you do more than that, you will get X% of bonus, right? So that is also a way to track CL services of, is there really enough volume to justify having 2 CL psychiatrists? They may, a hospital system may look at how many work RVU are coming out of the service. These RVUs are RVUs are assigned to each CPT code that is a billable code. And so taking the RVU assigned to whatever CPT code is sent in to an insurer. That is then also adjusted for geography because cost of living and so forth, and ultimately converted into a dollar amount that is hopefully the reimbursement you then receive. So we've talked about CPT codes, right? And how CPT codes get assigned RVUs, which get converted into money. E&M codes are basically a subset of CPT codes. They are CPT codes. They are just a specific category of them. And so CPT codes, these CPT codes are ones that, it's a nice practical thing that these are the codes for services where you need to evaluate and then provide management for a patient. So it's not like a specific procedure where the evaluation, and decision for a procedure would have been done separately. This is essentially the type of code that we will all be using on a daily basis. And so CP or E&M codes are divided into categories that in my head, I kind of think of as the setting. Is it an office-based service? Is it a hospital service? Is it, there's also like nursing facility codes, right? Then those codes are divided further into essentially, is it a new or a follow-up? Is it a new patient in clinic or established patient? Is it a new consult or a subsequent follow-up on a consult? And then within those set of categories is where we get to the fun part, and we're pretty much a big part of the rest of today is going to be about, and that's the level of service. And this is kind of the tricky issue, where level of service can be defined in two ways. You have a choice. You can do either based on the complexity of the medical decision-making that goes into your evaluation and management, or you can do it based on time. And different, which one you choose is going to be based on kind of how it went with the patient and what happened. But what's very important to know is that the level of service, essentially kind of the level of complexity, the time, the effort, ultimately the effort, right, that goes into it, will affect the RVU that has been assigned. And so here's an example. These are the E&M codes for level of service for an inpatient or observation initial evaluation. And I think you could probably guess which way goes, is the more complex or longer consults. And it's a pretty significant change in RVU. It's almost a change of one, every step. And so being able to accurately not overcode, we don't want to overcode, but accurately code to the complexity and to the effort you're putting into will make a huge difference in being able to demonstrate your value and also being able to be compensated as best we can at this point. So selecting level of service. Now, before January 2021, and this is kind of broad strokes, but before January 2021, with medical decision-making and time-based, we did it differently. For medical decision-making, you had to document like a required number of elements. And there were like, I don't know if you had these at your hospitals, but we literally had like checklists of things. We had crazy templates that we would get in the EMR, but you needed literally like 9 or 12 or 15, right? In addition to whatever complexity you actually needed to consider for your medical decision-making. Time, on the other hand, was that if the counseling and care coordination took up more than half of your time spent in the encounter, then you would bill based on that amount of time. But it could only be based on the face-to-face time that you spent with the patient or the family, and only on the date of the encounter. Now, in January 2021, there were some major changes brought in. And those changes essentially came down to, for medical decision-making, there was no longer the history and exam kind of number of elements required. It was based on the medical decision-making alone, the complexity that there was in that. You did still need to document appropriately for your history and examination, but it wasn't kind of like you had to have 9, even though 3 of them didn't actually apply, right? For time, it went to total time. There's actually an expansion of what was defined as time spent. And it was time spent not just face-to-face, but in the overall care of the patient. Still had to be on the date of the encounter on the same day, but at least you could include, for us as CL docs, time that you were literally sitting down in the family meeting, or that you were, explaining to members of the team your assessment, right? The catch is that in 2021, it was only for outpatient services. So what we did, SCL traditionally inpatient, didn't apply to that yet. Now it does. So in this year, in 2023, the changes in the 2021 outpatient E&M charges actually expanded to hospital inpatient observation, consultation, nursing facilities, prolonged services. There were a number of different changes as well, but this is really sort of what we're going to focus on today. And so, the rest of the group, will come up, and Junji Takeshita will talk about how time is being used and how you can count time and what counts towards it. James Kimball will talk about the complexity levels of medical decision-making. Andrea DeSimone will talk about unique circumstances that have come up now with the changes. And Patrick Ying will talk about support tools like online calculators and cheat sheets that can really help in the decision-making. And we really wanted to save a lot of time to do a skills workshop where we go through concrete examples of how this would look, on the day-to-day services in day-to-day, clinic. So I will pass it off to Junji.
Hopefully I can find my presentation here. Let's see.
Point in.
Oh, okay, there he goes. Okay, great. Thank you very much, Patrick. I'm Junji Takeshita. I'm a faculty at University of Hawaii, and I direct the consult service. Just a few housekeeping kind of things. If you look in the ACLP website, not the website, the app part, there's some handouts that are there. The handouts represent collective of a few of our organizations, and sort of the one-page cheat sheets. So you can see how our organizations have each done it slightly differently in terms of what they allow for and don't allow for. And then maybe if I could get a show of hands, how many of you guys are work RVU based in terms of your, okay, so maybe about half. How many of you are just kind of flat salaried? So maybe about, yeah, so okay, so fairly even. And then even though for those people who are flat salary, they often look at work RVU as a gauge as to what your productivity is. So whether you're paid with it or not, this stuff becomes an important issue. So in terms of a disclosure, I don't have any financial relationships. One aspect as a disclosure is that a couple of us are on the RVS committee as part of the American Psychiatric Association. It's not a conflict per se, but we're on this committee that helps look at these things from the APA standpoint. Okay, so how do you look at time spent? And the way that they define this is they call this like pre-work, the work of seeing the patient, and kind of post-work. So what do you do before you see the patient? This is a so-called chart review that the residents seem to spend hours doing. But you look at the records, right? You look at labs, imaging, you may look at the EKG, check the QTC, and then you talk to whoever's consulting you, right? The nursing, is it coming from the nurse? Is it coming from, and who's really wanting this consult? It may come from the attending, but actually it's the floor nurse who really wants it, or the nurse manager. And then you see the patient. So your standard examination, you talk with the family patient about some of your findings, things of that sort. That again, it's your face-to-face time. And then afterwards, you document, you order medications, communicate with the medical team. That's some of your liaison part, right? And again, the ordering medication, I know that's a real touchy issue. Depending on which hospital you are, you may or may not be writing orders. So you can say like, well, why are you writing orders? Well, it depends on the hospital. Like I've worked in hospitals where nobody but the intern writes an order, other places where everyone seems to write an order. So I'm not going to say which is better, but I have my opinions. And I think most CL psychiatrists have a pretty strong opinion about that. But having said that, that's part of your post-patient time. So this issue about time, it's really an alternative to medical decision-making. And it's really, some people think it's like, I don't know, I don't want to use a word like double bagging, but it's kind of like double bagging. I've had people say, well, I'm going to do medical decision-making and put the time down. Well, it's one or the other. It's not really a both issue. And some people have argued if you put both issue all the time, it looks kind of suspicious. So you should really do one or the other. So it's really an alternative. This is for when you're spending a lot of time, but the medical decision-making may not be so high. So you won't be able to capture the work that you're doing. So in your note, you have to put down how much time that you've spent. As Stephanie said, before it used to be this really weird 50% counseling coordination, blah, blah, blah. It's not anymore. It's the total time. And it's not just in the hospital, but the stuff that you got, you spent for the patients. For instance, like you saw the patient, you leave the hospital, you go back to your office, which just happens to be the next building, but it's technically not at the medical center. You get the phone call. Previously, you really weren't allowed to use that time. That was considered, you're not in the hospital anymore, but now you can. This time, some people will say, well, I'm going to include all the time, Well, no, it's the time that you're spending as an attending. So the time with that the resident spent, the resident spending an hour and a half doing a chart review, well, that doesn't mean you spent an hour and a half. You may have spent 5 minutes doing a chart review. And the medical student time, as you know, never counts, even though they spend even more time. And you also can't report the time if you report a time in some other separate, billing and coding aspect, or the travel time. And again, this issue about why don't they include travel time, I suspect it's because you can say, well, I had to drive 3 hours to go to so-and-so facility. I'm going to put that time in. And it's not really clear, well, you're in the hospital, you had to walk from one floor to the other. Well, I guess that time is somewhere, but that shouldn't be taking you, 3 hours. So I guess the government officially says you cannot use any kind of travel time. So again, the issue about using the bullets, the medical decision-making, that is such more common. Because if you do everything based upon time, you'll find that it has to kind of make sense. because you don't want the total time that you spent for your patients to exceed the, the hours in a day, right? Or the hours of your shift. It looks very suspicious. The other thing that time has done is that the government has now changed the time. For instance, if you look at the code 99233, which is sort of the high complexity follow-up, it used to be 35 minutes. Now it's 50. So it's actually more time, but that extra 15 minutes is supposed to take into account all those other things that you're doing that you could not bill for previously. They also have these new time beyond the 50 minutes. This used to be called 99356, 357. So now they have these new codes called 99418. And each one allows for extra 15 minutes. These are the kind of ones where if you forget and you put in 99356, your hospital coder will probably just automatically change it to these things, as long as you wrote down how much time that you spent. If you said something like, 65 minutes spent with this patient, then they'll put it as a 99233 and then add this 99418. This last issue about teaching time is kind of this. It's somewhat controversial. You can't use general teaching time. So, for instance, like if you talk to the resident about antipsychotics in general, that certainly giving a mini lecture, that's not going to count. But then what happens is, what if you give teaching that's specific to the patient? For instance, if you're doing patient teaching, you're talking to the patient about metabolic syndrome. Obviously, that counts, right? Because you're doing teaching to the patient. What happens if you're talking to your resident who's helping to manage the patient about, metabolic syndrome, the need to monitor weight, so forth, measure QTC, how you measure QTC, different formulas? Does that count? And we've actually had this discussion internally, both in this group as well as the APA committee. It is not entirely clear where this stands. And again, if you look at what it says, and I think Patrick was the one who pointed it out to me. He goes, it says you can't have general teaching. That sort of implies you can have specific teaching. Is that really true? It's not exactly clear. So all the stuff, for something like time, you think it's black and white. It's not. It's not black and white. So, and I think that's my last slide. And then we'll go to James. So talk about more about the E&M stuff. Okay. Yeah. So So I think are you going to be talking about 90792 in your presentation? No, okay, so I can answer that question. So 90792 is a non-time-based code. So it has nothing to do with how much time you're spending. So that's a non-E&M code. So you can spend 1 minute, 2 hours. Yeah. Yes. So that always comes up is when should you use an E&M versus the 90792? If you're doing a comprehensive evaluation of the patient, a 90792 makes a lot more sense because it's 4.25 work RVUs versus the highest E&M, which is 3.5. So. Yes. Well, the reason why what to use kind of makes some of a difference is depending on which site. Well, it depends on the insurance. Some will allow more than one 90792. You want to be able to preserve one 90792 with some other service doing the, the initial high-level E&M.
Also, in the emergency room, some carriers deny 794, because RVU is much higher than, for whatever reason, that emergency room evaluation codes.
Right.
It doesn't make sense.
Right. It doesn't make sense. Yes.
allow the 90792 only a certain number of times per episode. And so if that's an episode of depression, that may last someone many years of their life. So it's different based on carriers, what they determine as a new episode. So I know in my hospital, if I do a 90792 and it doesn't count, they will change it for me.
Yeah.
So are they, like, how much backup do you have in your system on catching those things? Because, like, for example, yeah, it's just benefiting that if they hire assign RVU, but if you use it when you're not supposed to, then you're kind of out. So.
Okay, and maybe I'll take one more question because I know we have a lot to cover, and then there's the interactive calculator as well as actual examples. So I want to make sure we have sufficient time. Maybe I'll take one more question. That's correct. That's correct. That's correct. Yeah, thank you.
We actually used to record and high level when we had to do the documentation and portion of it, that was a big part of that. Sometimes too, all these the EM for kind of put psychiatrists in a position to document things that were not repeatedly documented,
All right, so hello, everybody. James Kimball, work at Atrium Health Wake Forest Baptist in Winston-Salem, North Carolina, and I have no disclosures. So hopefully trying to make coding and medical decision-making a lot easier. Sometimes your institutions may give you a handout or something that looks like this, and you might think, oh my God, this, like, how can, number one, it's written in super small font, so how can you read it? And then how do I know I'm doing it right with all the stuff that's there? Stephanie talked about RVUs already, and it's the amount of work paid for the service and things like that. All right. Well, here's the thing. Relax, right? Part of it is, why do we go into this field? We didn't go into this field to maximize coding or things like that. We went in this field to take care of patients, right? And I believe if you take good care of your patients, all the RVUs are going to follow. So point is, put patient care first and foremost. All right. So when it comes to medical decision making, you have to have 2 out of the 3 elements that are there. And you have, part of the 3 columns, nature and complexity of problems. You have the amount of data that needs to be analyzed and the risk of complications. And so there are 4 levels: straightforward, low, moderate, and high. And we'll go through each of those. So, so I guess I should start with the straightforward part. That, they talk about a self-limited problem. Okay, well, a self-limited problem could be simple, like bereavement. So what, basically we have to define what a problem is, and basically it's a disease, condition, or injury. You have to address or manage the problem yourself. You can't just say, well, the person has diabetes, or hypertension, if it's not playing a role into what you're doing. So, so you have to do something to address or manage it. A self-limited or minor problem. So it's a problem that runs a definite and prescribed course. It's transient. So here's some examples, right? A 67-year-old with insomnia who's deciding whether or not concerned about COVID. Might say some melatonin. A 34-year-old who questions whether they have seasonal affective disorder and wants to know about phototherapy. Something that is very minimal risk, and that would be considered straightforward. So now we're going to go to the low part. And so one of the things in low medical low complexity So one of the things there, it's a stable chronic illness. So stable means the person is at their goal. So you have treated this person. They are, you do whatever rating scales that you might use. And basically they're on maintenance treatment. We're good. So if they're not at their treatment goal, so if they still have depressive symptoms, you do a PHQ-9 and it's 14, they are not at their goal, basically means they are not stable patients. So for example, you have a 50-year-old patient who's got bipolar disorder, completely stable on aripiprazole and bupropion. That's a stable chronic illness. You're not doing anything more. And then also under the low complexity, you have acute uncomplicated illness. It's a short-term problem, probably no risk of mortality, full recovery is going to be expected. So a 22-year-old whose boyfriend left her for her roommate has some depressed mood. They basically have an adjustment disorder. All right. So as we move down that first column into the moderate medical decision-making, there's a couple different things there. So, so chronic illness. And basically, when you think about it, these are probably a lot of the patients that were consulted on because it's worsening or poorly controlled or progressing. Most of us probably aren't seeing or aren't being consulted on patients who are stable. So an example, you have a 50-year-old with a lot of diagnosis of depression, but their mood symptoms persist. Patients can have an acute illness with systemic symptoms. This is also a moderate complexity. So you have an illness that causes systemic symptoms and has a higher risk of morbidity without treatment. So for example, the patient with a substance use disorder who's presenting an acute withdrawal. Also under the moderate decision-making, they talk about an undiagnosed new problem. So for example, you have a patient who you're consulted on and they have a 1-week history of cognitive decline, but they don't have a history of dementia or anything like that. So that would be an undiagnosed new problem. And as psychiatry, we're not really dealing with acute complicated injuries. And then if you go still going down to the complexity, if you look at the high complexity, so chronic illness with severe exacerbation, progression, or side effect of treatment. So there's a significant risk to morbidity and may require a hospital level of care. So for example, the 46-year-old with bipolar disorder on manic symptoms, the person who's akathisic from treatment of schizophrenia with antipsychotic medicine, the person you see on this consult service who overdoses, and they have a history of depression and they overdose. That would be a chronic illness with severe exacerbation. And then, you have an acute or chronic illness that poses a threat to life. So this is also, for example, the suicidal patient. All right. So just as a reminder, straightforward is self-limiting. Low complexity, patients are stable. Moderate, they have multiple problems or significantly ill. And so even thinking about that, multiple problems. So let's face it, a lot of us see patients who have a mood disorder and a substance use disorder. And they can be stable problems, but if you address both of those in your note, then that's moderate complexity. And then, high complexity, that's really the severely ill folks. All right. So in the second column there, the amount and complexity of data to be reviewed and analyzed. So, for the straightforward, it's really minimal. And then for there is, that you have to have, you have to meet one of those two categories in the box. So basically reviewing tests or documents, or looking at an independent historian. So part of the test, looking at external notes from each unique source. So what does that mean? So basically an external physician is one that is not in your specialty or subspecialty. So you know, or it could be from another hospital system or something like that. So if you're doing inpatient consults and you're reviewing, say, the internist note, for example, technically that would be an external physician. You also review unique tests. And so they define unique tests as basically what's in the CPT code. So for example, if you order a basic metabolic panel, you can't say, well, the sodium's one test, the potassium's one test, the chloride's one test, right? Can't do that. It's all one. But let's face it, if you order a CBC and a BMP and a TSH, that's three tests. All right. And so as you can see, going down the list, you know, for moderate data to be reviewed, you know, you now have a third category, you know, and looking at independent historians. What's an independent historian? Basically, someone you're getting another history from. And basically, you're saying that because the patient is unable or unwilling to provide a history, you know, or because you feel that, hey, you know, I need to do a confirmatory, you know, get collateral information, right? That independent historian, you know, is important. One of the other things, looking at independent interpretation. So just because a test is ordered, you know, you have to, you know, you just can't say, well, someone else ordered the X-ray and I wrote it down. You have to independently interpret it. So I will just give an example from my, you know, in my institution. So I do a lot of primarily inpatient psychiatry work, and we had a patient who said that he swallowed a golf pencil. And okay, fine, sent him to X-ray. And the radiologist said, there's nothing in there. But my resident and I looked, and even though I'm not a radiologist, saw something funny, it looked like a golf pencil, and it was. And GI was not happy with us. So, but that was my independent interpretation. And then discussion, you know, you have to document a discussion with somebody. You can't say my resident discussed it with someone else. You know, you have to have that there's a discussion with the provider. It doesn't have to be long, but it just says, you know, I talked to so-and-so about my findings. All right. And now here's the thing, when you think about it, you know, most of our patients, you know, okay. So moving on. Okay. So moving on to risk. So, you know, we have minimal, low, moderate, and high risk, you know, and so basically low risk, a new patient for an adjustment disorder, you referred them to a therapist. From a moderate standpoint, most of our patients would probably be in the moderate risk standpoint because we're prescribing them medications. You know, so if you're prescribing medications, you're already in a moderate risk. You know, and then patients who are high risk, you know, these are patients who they need inpatient admission, or you're talking about increasing their level of care, maybe to a 1-to-1, for example. You know, also they talk about drug therapy requiring requiring intensive monitoring for toxicity. So these are patients that you're going to institute on lithium. These are people that you're probably going to start clozaril on. Now, to be clear, not every patient on lithium or clozaril is going to be high risk, but at least in the beginning stages, when you do that, you know, that would be considered high risk. These are also patients that for a need for parental controlled substances. So patients who need IM Ativan for catatonia, for agitation, you know, that would be a high risk patient. You know, also patients who need medications over objection or forced medications. Now, if you look at the moderate, this is also a change looking at social determinants of health. So if the social determinants of health affect your medical decision-making, you know, that's also automatically moderate risk. You know, homelessness, food insecurity, and things like that. All right. And then, you know, I talked a little bit about the drug therapy requiring intensive monitoring for toxicity. You know, basically it's, you know, just if you have a patient who's stable on lithium and you get a lithium level every 6 months, that's not really count because they're more a stable patient. You know, these are patients that you're doing more frequent blood work on. And, you know, you're really making sure that those patients aren't toxic. You know, and so if, you know, taking all this into complexity, you know, taking it all as a whole, you know, if you're, you know, if a lot of times, sometimes it's easier, at least I find it easier to basically look at the third column first and say, okay, well, you know, if I'm, you know, am I prescribing medication or is it a more higher risk? So moderate or higher risk, I'll look at the first column and think, well, for example, you know, do I have am I being seen or consulted on a patient with stable or unstable problems? You know, and then, you know, sometimes, at least in my experience, sometimes the second column can be a little bit challenging, depending on how long you're seeing the patient. But, you know, but that's typically what I do. So I do believe that a lot of us underestimate the work that we do. A lot of us have been doing this a long time and it's just rote for us, you know, but don't underestimate that. You know, don't shortchange yourself. Say, keep it simple. Thanks. Is there a question? Yeah.
How some of the data that you're using impacts clinical decision making, like the fact that you reviewed it is not adequate. Understanding how to demonstrate that without making our notes.
You know, you don't want to have bloat in your notes and just, you know, copy forward every single lab that they had over the past year or whatever. But I think ultimately you're right. How, you know, may not matter so much if, okay, you see a person with depression and you're going to suggest an antidepressant, but if someone's on lithium or you're going to think about an antipsychotic, you know, then the A1C and, you know, glucose and metabolic labs are going to be important. So.
Write somewhere like this person has a hypercyclemia, I have interpreted it.
How does it relate to the patient?
But in the imaging that you were discussing, it wasn't clear if you actually wrote the interpretation, like in a specific, like clear section of I read this imaging, I saw the golf versus this person appears to have a golf pen, I think there's stomach still, which is like, again, it's one step separated from I interpreted this imaging and I said.
I think you have to say that, you know, that you independently interpreted it and this is what you noticed. And then same thing like with an EKG, you know, looking at QTC, if you said, you know, well, you wanted to take out calipers and interpret it yourself, but I think you have to say that.
When you write, continue the medication, outpatient, for example, we often prescribe long duration, but in the note, you know, you can see the patient a month later, and then if you write continue the medication, does it?
Yes.
It's complex, right?
Well, yeah, it would, because you're prescribing a medication, and you don't have to write a medicine for every visit, but if it's under your care, then that counts.
I guess the new terminology medically appropriate and like some people are still pretty fixated on sticking with like two system. I'm just wondering, like, what is considered like a norm, I guess, for what an appropriate history physical. And if I wanted to go back and like look at that and thought of that and say, oh, you didn't do appropriate What is appropriate, I guess, just based off what I do, because if it is, and I say, oh, that's it, but it seems to be back to the I don't know, it just seems very, very vague.
Yeah, you're right, it is vague. I think you have to do based on what you were taught and how, what's best for the patient, not just depressed, suicidal, admit, but something that's more detailed that says something about the patient. Right.
Really not get any more really have forward, but it should say something meaningful. I mean, I usually write at least one sentence about why they came in, and at least one sentence about the examination, so it's clear that you saw the patient. Otherwise, but is that technically necessary?
Yeah.
It's not. It's technically not necessary.
In the update, which on custom slides, there's a link to the documentation. It actually describes that for the purposes of putting billing, they don't. You didn't even have any history and examination, whatever. They're just putting it all on your mechanism. However, it does actually state a caveat right next to it, which is, however, appropriate history and physical is necessary for other reasons, such as, we cannot have. So at least in terms of billing, it literally does not.
I just want to add to that issue about involving students and residents. So student notes, you can always use for review systems and family social history, so for the 907, 93, that. For E&M, there really isn't anything that you can use for the medical student notes. The resident notes, as long as you write a proper path note that is attesting to it, you can use the resident information for the E&M. So again, it's not a proper attestation. They need to, I've had residents do a cut and paste of a student note, and I tell them, please don't do that. They're supposed to write their own. Yeah, there's always somebody doing it.
All right, great. I'm Andrea DeSimone. I am a CL psychiatrist at Bay Health Medical Center in Dover, Delaware, and I'm going to talk about a few unique circumstances. So first, I'm going to talk about billing for complexity and prolonged services. I will talk about billing for critical care services, as well as patient phone calls, as well as curbsides. And I have nothing to disclose. So first, let's talk about billing for interactive complexity. That's the 90785 code. So mostly where I would see myself or other CL psychiatrists using this code would be an add-on for the 90792. You can also use it for psychotherapy services and to group psychotherapy. And it accounts for complexity. So that's communication difficulties during the interview. Unfortunately, cannot be used with an E&M code. So these complex situations include a need to manage maladaptive communication, caregiver emotions that interfere with treatment. If there's a mandated reporting event, you can also use this code. If you use play equipment as a child doc, if the patient's not fluent with the language, or there's some barrier that they're unable to communicate with you. So like a person with aphasia. Going to billing for a prolonged visit, I'll talk about both inpatient and outpatient. Let's first start with the outpatient codes. So these are for these are add-on codes to the 99205. So that's the highest level of billing for the outpatient intake, and the 99215, the highest level of billing for the established patient. So there are two different ways of billing for these based on whether you're billing Medicare billing or a CPT code. So that would be for those patients that are non-Medicare payers. So you can use this for chart review, time seeing the patient, so face-to-face time, time spent after the visit with documentation, or care management or other kind of care coordination. So things like speaking with social work about these patients. And it cannot be reported on the same day as psychotherapy codes. So for example, let's take one example. So say you have a 99215, you spend 67 minutes total in that encounter, both before, during, and after. So you want to bill for 67 minutes. You need to subtract the highest amount of time that you can bill for that with the 99215. So that's 54 minutes. So 67 minutes minus the 54, you are left with 13 minutes that you've spent over. Now, so things get a little interesting. So with a Medicare patient, you need to have the full 15 minutes. So you need to meet and exceed the 15 minutes to be able to bill for that chunk of extra time. So for a Medicare patient, it's only a 99215. For an outpatient where you're billing commercial, for non-Medicare rules, you can bill a 99215 plus the 99417, 1 unit in this case. So going to the inpatient side, I wanted to focus only on the CMS codes because most of us tend to just stick with the CMS billing. So for an initial, it's the 99223. So that accounts for 75 minutes. And the subsequent is 50 minutes at the 99233. So again, you need to meet or exceed the 15 minutes in order to start billing for that for Medicare. So that's 90 minutes for the initial and 65 minutes or more from for the subsequent visit. So again, as James said, all of these things count for time. So this is the chart review. This is the prepping the note. This is gathering collateral, counseling family members, ordering medications, tests, or procedures. So for me, that's a nice 10-minute chunk if I'm doing a MOCA on a patient. Coordinating care, referring to other professionals. So sometimes in my hospital, I am doing a doc-to-doc. So all of that counts for these things, as well as the documentation itself. For critical care services, I spent a lot of time on this because I heard rumors, apparently, that psychiatrists were billing for critical care codes. So I spent a lot of time trying to get to the bottom of this. So apparently, after all this digging, only the primary team, the primary critical care doc is able to bill for critical care time. So I said, okay, well, what about the cardiologist who comes in for consult in the ICU? Can they bill critical care time? No. They are still billing for the regular inpatient code. So it is only the intensivist that can bill for the critical care time, not us, unfortunately. So the 90792 or E&M codes for the patients who are admitted to ICU that we see. Returning outpatient phone calls. So we can bill for outpatient phone calls. So there's, of course, CMS and CPT codes for this. For CMS, it's the G2012, and this is the Brief Communication Technology-Based Virtual Check-in. It's a very long name for this code. Telephone is allowed for this, so there is a caveat that you can bill for a telephone encounter. So for both of these, it cannot originate from an E&M service in the last 7 days, and it does not lead to a related E&M service. And that it says within the next 24 hours, or if your note says something like the patient needs to come in for next available appointment. So it's not just 24 hours, it's an unspecified amount of time in the future. And verbal consent is required to be documented with both of these. So there are two. There's a 2012, which is 5 to 10 minutes of medical discussion. It's 0.41 RVUs and $14.78, which I found fascinating. And the G2252, which is 11 to 20 minutes of medical discussion. Okay, so going to, yes. What's that?
What do you mean by verbal consent?
So just that their insurance will be billed and they may need to pay a copay. Yes. Yeah. So with this, and I didn't include it, and your question brings up another issue, is that you can also bill for returning patient gateway messages or MyChart messages. You have to document that they consent to this. So in the outpatient setting, it's a little bit easier to do, because if somebody comes into your office and says, we're gonna start a doctor-patient relationship, you can have them sign consent for that. That if if I'm returning a phone call, or if things, if things start to be too much to return all of the patient messages, your insurance may be billed. The Most that I could find about what might this actually cost a patient was like $2.50. Like somebody cited that as an amount. It brings up some questions of, should we be charging for this? Should we not charge for it? I can see both sides of it, right? Because on one hand, these take a lot of our time. This is a lot of time. And on the other hand, our patients just want to talk to us. So it creates some questions. I think more questions than answers, because like 1.08 RVU for 21 to 30 minutes of work, I mean, doesn't seem like, I mean, when I've spoke to my billers about it, they were like, really, you want to bill for this? Like, it's not worth my time to proofread your notes and check them for you. So, yeah. So same thing for the CPT codes. It's 99441 up to the 443 based on time, are not really reimbursed very well. And so lastly, for the interprofessional consult code. So this was particularly interesting to me because I'm in a small hospital that has a more rural site about a half hour to 40 minutes away. So I was starting to get a lot of phone calls from the people who worked at both sites, like, hey, can you look at this chart and see what you think? So I thought this would be a great way to quantify what time I'm spending doing this. So here is the checklist about what needs to be in the encounter. So there's no face-to-face encounter with a consultant within 14 days before or after, really. So it's 2 weeks before and 2 weeks after your curbside. That's difficult, right? Very difficult to have. Verbal and written report required. That's easy. We can do that quite easy. But for Medicare, patient consent does need to be documented. So at this point, we're relying on the primary team, on the internist, to go to the patient and say, I'm going to consult somebody who's not going to see you, but they're going to bill your insurance, and this cost could be passed on to you. Are you okay with that? And so that does need to be required. That's required to be documented by the primary team. And I personally didn't like that I was relying on an internist to do a consent for a service that I was providing them for maybe $30 bucks. Like, I was like, this to me is not worth it. And the amount of time that is spent, the kinds of things that I would be doing, this would lead to a face-to-face documentation, at least by one of the telepsychiatry doctors within the next couple of days. So for me, it wasn't particularly worth it. It's much like my attendings told me when I was a trainee, just go see the patient and bill the E&M code. So yes, and that is all for me. And I will pass it to Patrick.
Right. I'm Patrick Ying. I'm a CL psychiatrist at NYU. I'm also on the APA's committee that deals with this kind of stuff. All right. I have nothing otherwise to disclose. All right. So what I did is these are kind of the big resources for this kind of stuff. If you want kind of the original texts, the CPT guide, and then of course things, advice from CMS. CMS has different rules, and it's always good to know what CMS says, because they can make your life a lot more difficult if you get this wrong compared to the private payers. And then the APA also has some great resources. So I've kind of taken all of this stuff, a lot of the stuff that's been covered here, and I put it into this kind of online coding calculator. All right. So give a second for people to kind of either type that in or put the QR code before I switch over. So this was kind of born of necessity. I kind of did this because we were kind of going through the same process, having these cheat sheets and whatnot. Okay, when the phones come down, I think I'll all right. See if I can switch this out here. And this is all stuck here. Now, you guys see that? All right. Oh, here we go. All right. So you should have this on your phone. It works on mobile devices and on websites. So this is kind of the same thing we saw in the in James' presentation here, right? So you start out with the problems, and you can kind of select one, select a level. All right. We've got here the descriptions of what makes each level of problem. All right. And we also have some of the psychiatry specific examples that were developed by the APA. And if you're looking for the kind of definitions of what's considered chronic, you can kind of hover over the question marks here. You can, on the phone, it may work better to just toggle this, and you can get all these definitions here. Okay, so you can pick out the problems. Now, one thing in terms of the CL perspective, I just want to see what some like other people think. When you look at problems, I think a lot of times, to get to the highest level, you need things that are life-threatening. And I think CPT means for the thing that we're treating that's life-threatening. So sometimes we're treating people for kind of not ordinary, people that are really sick with other things, with less complicated psychiatric issues. So sometimes it can be harder to get to the high level for CL of the way things are defined. Likewise, here we have all the data points. All right, so you can we've talked about the unique tests. You kind of select this. We're frequently doing discussion. And again, it has all the great definitions that he had from his lecture here. All right. And then risk. All right. And the other thing is risk is the risk of treatment. And I think that's another tricky part, that our treatments are pretty safe, even though they're sick people, right? Now, things like monitoring QTC, parental controlled substances, right? Those can get you to the high level. But it's a little bit, what's the word? Sometimes it makes sense and sometimes it doesn't, just the way it's defined in terms of high risk, but because it's a little bit particular, again, here, if you look at kind of what the definition of intensive monitoring for toxicity. So it has to be a test. So like people say, well, if I'm looking for tardive dyskinesia, exams don't count. It's just the way they've done it. All right. So you put those in, right? It'll tell you what the levels are and then what the level of medical decision-making is. And let's say you do an inpatient follow-up. And, also, if you want to put in time, how much time are we spending the follow-up? 50 minutes? All right. It will generate for you, if it's not stuck, a code. All right. That's over there. Okay. Let's, anyway. That's not on my screen, so okay. So, here we go. And then it'll also give you a code for the time. All right. And one of the nice things about this is the whole prolonged services thing was described is very confusing. CMS has a different threshold on outpatient, and then in March, they changed their threshold for inpatient, so it's the same as CPT. All right, so this is up to date, but it will, this will generate a prolonged services code for you as well. We do like that. So, and also you have the option for psychotherapy. Okay, so this is kind of an online way of encapsulating all those cheat sheets. And I have a disclaimer for education purposes only. These things change a lot, so I don't want to, it's for you guys to learn. If and I think that this should be really helpful with that. Okay. So I think we're going to go to the. We have some cases set, and see if that's this is online polling. If you go to menti.com and enter the enter that. This is just a way of kind of making sure people are working with the software. We have some cases we have preset, but if people have questions, I think it depends what people prefer doing. Yeah. So.
Most of my time, is that sometimes walk in the so my time management, time not long, the level of complexity of those I think it's go back to what we look at like what's the concept and like I guess it's a patient who has chronic schizophrenia and is often happy because they're so significant and complicated. Okay, that's pretty easy then to actually go through the MPN with like, the moderate severe category. If it's something where it's really not there's not a lot of complexity, but you do have to spend a lot of time. I found that the capacity is that still easily that because of the time you can talk to people, so it does sometimes take a little bit of time looking back over the criteria and you can work that.
I think the other thing you can use for that, you want to get a new patient to question. I don't time this for the inpatient, but if you do that, you have to start with 40 minutes spent and then starting time, or you simply say, stop, spend 40 minutes.
So I clarified this with our billing department, but I would still recommend you clarify it with yours. Ultimately, they're the ones who are going to talk to you if you put it on. But our billing department said very clearly that you do not have to start top time because it's going to be done. And they clarified with whoever they clarified it. But similar to outpatient, you don't need to be start top time because the encapsulated sleep time. But especially if it's longer, you should be.
If it's longer, you should also put like a little a few words after about what it was spent on, like with family meeting and extensive discussion with primary team. Yeah.
That was so is that best practice or what?
So so the question was kind of adding in a few more words about what the time was spent doing, whether it's best practice or whether it's sort of actually expected. In the AMA update, it does the guidance, it actually does suggest that you clarify or like put in briefly what it was spent on. And I think they give an example where it's like where it literally was at clarifying with family and discussing with primary team options, something like that.
I have a question over here.
Hi, thank you, everyone. Has anyone ever considered how good the billers are? Because when I track down the billers, and they've tracked, they look at our notes, but we rarely see who's behind the mask and the screen. I wonder if there's some way to hold them accountable or maybe hold them to some level of understanding or education. I know this is a controversial question, but when we write risk assessments, I have my team and we don't we don't leave a note without a risk assessment. There's a risk assessment on every single note we write, and I'm 100% inpatient CL. So my notes say no acute risk, and to the biller, that means the patient's completely stable. So they may be prone to down code my notes, but that no acute risk might have been generated by 15 hours of collateral. So you know, again, if I don't have the 50-minute time on the follow-up, but I've made this whole consideration, you know, for psychiatric admission, then the comment even itself, you know, for the high complexity, I've considered psychiatric admission, but I'm not doing it. It feels strange too. Just wondering if you've actually peeked behind the screen and held the billers accountable for some of their work.
I mean, that's how I generated, I made them give me something for the curbside because they were telling me, don't do it, don't do it, don't do it. And I was like, I don't understand why I can't bill this. So that's how they directed me to that like checklist. So what they called it was like, this is what I use when I'm doing a chart audit. So you may be able to ask them for something like that, like what they use for an audit.
Yeah, I actually got into a huge battle with our billing department because they were saying that a 90792 is a biopsychosocial evaluation. I need to specifically use those words. And I said that nowhere does it say that. Unfortunately, they found this obscure document that mentioned something like this. And since they're doing the billing, I couldn't argue with that. So now our 90792 has this silly documentation saying biopsychosocial assessment. It was just easier sometimes, but you're right. It's sometimes it's a losing battle, and sometimes it's just not worth it.
Would you like to comment a little bit on the add-on psychotherapy codes, especially for people who are seeing cancer patients? We tend to do a lot of therapy with each visit, whatever complexity it is.
Yeah, so psychotherapy, it's not really a place of service. So a lot of times we think about psychotherapy as outpatient, you know, in your clinic, but you can do psychotherapy in, you know, in the hospital and use an E&M code, you know, if you're adjusting medications or something like that, you know, as well as the time that you spend in therapy. And the note just has to reflect goals, you know, what were the goals of therapy, you know, what, you know, CBT or whatever other technique that you used.
Just thank everyone for your time, and all this information is very helpful. I wanted to ask about the add-on psychotherapy. You cannot, as far as I understand, you cannot add it to a 90792, but you can add it to a 99205 or a 99215. For outpatient, this is all outpatient stuff. Is that right?
Yeah.
You cannot bill by time if you use a psychotherapy code, right? Or the psychotherapy is the time-based. Okay.
Yeah, you can add it to it. Yeah, you're allowed to add it to an E&M, but you cannot add it to a 90792 because 90792 is sort of, yeah.
I think the more unusual aspect was like, can you add it onto an initial, right, E&M, right, 9205? There's no reason why you couldn't by the books. I think it's a little unusual. I mean, but that's only because I think most of us are using 90792 for the initial anyway. But yeah, I mean, by the numbers, you're allowed to add it to initial E&M. It's a little weird.
I wanted to reiterate the thank you for someone in their first year of attending Hood. This is pure gold. I did want to ask if people were using 99255s on the floor and 99285s in the ED, and what's your sort of engagement with the billing been around that?
Our billing department said that in the ED, we not to use 99285. So basically, you know, we use the outpatient consultation codes 9924445. And then for inpatient, 99255, if the payer accepts a consult code.
Again, and
I'm confused. Why are you not using the 283 codes? There's a specific for emergency code, right? 99283, 99283, which is moderate complexity.
Right. I think every institution's different. And the way our institution reads is that we're consultants to the emergency room, and so using the outpatient consult codes.
Hi, thank you for the talk. It was really helpful. I do a lot of addiction work and my CL work, and I'm wondering about detoxing people with methadone, buprenorphine, or like from alcohol. I've been considering that high in terms of like the medical decision making, that it's like severe threat to, life or limb. Do you think that's correct, or do you think it depends on the situation, depending on like how sick the person is? Because most of these people are super medically ill, and I probably wouldn't be detoxing them outpatient. It's because they're admitted to the hospital.
I mean, I would make the argument, it just depends, on the patient themselves. So if it's just a person drinks a little bit of beer and you're going to admit them for detox, do they even need inpatient detox? But if it's someone in the ICU and you're doing CWAS and their CWAS 18, 19 or something like that, then that certainly increases the risk.
Yeah, I mean, like sometimes they're in the ICU with endocarditis from their opioid use disorder. And, they might have pain from like whatever else is going on. So to me, it seems like they're high risk. But
I think as long as you document that, okay, my person's has an opiate use disorder, they're detoxing, but there's all these other comorbidities that I have to think about, in choosing whatever regimen or recommending whatever regimen that I'm providing. So it's not just, okay, person's going through opiate withdrawal, methadone detox or whatever you'd use. I think documenting the other things that, your thought process.
does that go in the assessment then? Like if I'm just putting that in my assessment, like this is why I'm doing what I'm doing, my medical decision making was high, or
I think that's fine. So.
Thank you.
It's an exclusionary criteria in the coding. It just literally says it. Yeah, can't be used with the E&M code. I know. It's really sad because it's, yeah, so sad.
Oh.
So if you want to bill E&M and you're using an interpreter.
Oh, no, the answer is yes and no, because what they don't want is the patient to get additional bill just because they don't speak English.
Okay.
But if you're using it in some way, then, again, it's one of the big things, the amount of E&M you get from, the amount of work you get from a 9075 is really not very much. It's very unclear.
Okay.
It can solely be used for interpreter services. Specifically as exclusion. And then they have the other bit where language may be a factor in education. Yeah. So
right.
You do it into it, but if it's truly just because an interpreter was used, then no. If it's an interpreter was used and there were other elements of the communication that were challenged, then yes, that's
exactly correct.
That is, so it's perfectly said.
But I guess you could
do often cause
think-
the visit to take longer.
Right. You could get it on time.
I think one sort of potential example of that is like, again, not just for interpretation, but if there are significant linguistic and cultural issues that are further complicating it beyond just the direct interpretation, that is when, that's when you can kind of bring that in. But again, it's more of a little nuance to kind of like add in, this was an additional complicating factor as opposed to, being kind of routine.
I don't like answering questions, but there was a question about E&M codes or about codes for the ED, and we recently were told the ED is still being treated as outpatient, but for a while OBS was still being treated as outpatient. That apparently changed over. I don't know if that's true or not. That led to a lot of confusion or coding. The question I have for you guys is kind of related. We have a number of people that we provide essentially boarding on OBS for primary psychiatric care. They're waiting for a bed to come up. Do they count as high complexity because they're kind of already psychiatrically hospitalized? So it's not like we're recommending it. Like, does that count?
So they're physically still in emergency.
No, they're admitted.
They're admitted patient.
Yeah, I think these things are, but now we're using, because the rules change, we're using, but I still think that's class because they're admitted for psychiatric care, so it's not like they're recommending, but they're not.
From that perspective, you're admitting that for the acute exacerbation of a condition, which puts them and requires hospital level care because of some level of safety that without that intervention, they are then at risk, right?
So is that, so they're.
That would be your high, that is a high risk, that's one element, high risk, right? Now you need to go into the other two boxes. So either you're doing a whole lot of data review or talking to a bunch of people or doing interpretation of tests, which you may or may not do, or you now have a number of conditions which you're actively treating them for, and you probably have at least one severe exacerbation of a problem that put them there. So in that setting, it would, by that
Right,
logic,
so-
this button will probably say,
Right. It'd be high here and then for risk, right? Yeah.
You're recommending, right? They just haven't gone there. You continue to recommend.
and you're probably still doing all kinds of other things, right? They probably have like a 1-to-1, or there's lots of other interventions that are going on, like all of those things that in the absence of them would lead to a severe consequence from this person adds to the level of risk and complexity that you are doing to do that. And the same thing would hold true for, say, a patient who has alcohol use disorder, is in your hospital, that without active treatment, were they to develop DTs or alcohol withdrawal syndrome, which can be a life-threatening condition, it is your active treatment and management which is preventing the emergence of a life-threatening condition. So it is an active treatment getting you to where you need to be. And then we haven't talked about delirium yet. I'm not sure how people conceptualize delirium or encephalopathy and how they choose to code it or not code it, and whether they consider that high risk or not high risk, or a life-threatening condition or not a life-threatening condition. So I'd be curious what you all think about that.
I add to that. What are people coding for
a diagnostic code for delirium? Because I think there becomes confusion. I traditionally had used the FO5, which I'm often told won't be covered by. So is that R41.9 or what? Yeah.
Yeah, it's toxic metabolic encephalopathy, bills higher than delirium.
And what is that code, or what is that? Is that the R41?
I search for toxic metabolic and it comes up.
Yeah, or search for acute encephalopathy, whenever you're diagnosing delirium, your diagnostic code should always have acute encephalopathy in it. And then you try to specify further as much as you're able to, if you know what the kind of main precipitant is.
Yeah, our billing rules, so you can, like, if you type in like encephalopathy or acute encephalopathy, our billing folks automatically always change it to acute metabolic encephalopathy. Even if it's from an infectious cause, that's what they'll change it to, because they'll get the most RVUs that way. Just as a heads up.
I don't think you can use that particular diagnostic code with a 90792. I believe the 90792 would require an F code, but the E&Ms, you would have more choice in geometry diagnostic codes.
I only see pediatric patients either in inpatient medicine or in the emergency department. Often I'm doing a full evaluation on this is the first bite at the apple. And I simply, all those little 15-minute, should I do the E&M thing? And then like if it's taken a long time, I've got to talk to both parents, et cetera, just drop like 8 15-minute codes afterward? Or should I do that, the 90792 evaluation code?
Actually, it depends. I think the E&M, the bunch of the 15 minutes probably more accurately captures the amount of time you spend. You could do the 90792 more than once, which is what some people will do. They'll do it on day 1, and they'll do it on day 2.
I can drop that code twice.
That's kind of-
Oh, I never knew that.
Yeah, and then you have to say within it, like why you needed a second shot at it.
Yeah, and usually I spend a lot of time and do a real big note and everything, and I don't know. So the 15 minutes,
that would be one way of
capturing more of these RVUs, or okay. It just seems weird dropping the same code 8 times after I've seen.
It's 2 hours and
Yeah, it is. Okay.
There's also some great, you can just Google like RVU calculator, and you can generally guesstimate how many of those extra prolonged 15-minute codes it would take to become equivalent to the 90792, and then go from there. I think it just sort of, depends, but if you typically, I think if you say what happened, like there were we had to talk to X, Y, Z, still wasn't able to get a hold of Z, can't make a clear, plan without Z. And so it's kind of next day, and that's why we had to complete, like how to do it again.
After Dino's question before, I wanted to make sure you got this question.
Yes, how do we feel about delirium, or it being high complexity versus?
Delirium is a life-threatening condition, acute brain failure.
Question. So I guess just to clarify, we're billing as encephalopathy, but we're not writing the word in our notes because
I am.
do you guys write encephalopathy?
Yes.
So you've all adjusted to writing encephalopathy, not delirium.
Yes. It
That feels dirty. That feels very dirty. I don't know if I'm the only one who needs to take a shower after this lecture, but
Actually, it's interesting because I still use the technical 5 diagnosis, and although I haven't made a big fuss about it, because I'm writing delirium in my note, I'm coding it as delirium. But I know this issue that encephalopathy is neurologists always call it encephalopathy. Right. It seems more medical, hence the higher, issue.
Yeah, no, and that's exactly what it is. But technically, it's like delirium is the behavioral manifestation of the encephalopathy, which I find to be at least boggles my mind that there's that distinction.
Right.
But the medicine doctors tend to listen more if I call what I'm reading encephalopathy versus delirium. And if I can get reimbursed kind of for that, I call that.
yes, and we whisper delirium at the nursing station, but we call it encephalopathy, but we still write it as delirium because the DSM calls it delirium. So are we leaving the DSM as CL psychiatrists? You know,
hospital reimbursement that's higher. The psychiatrists work hard to get credit is actually the same because it's not based on diagnosis and what you did. But the hospital actually gets paid more because it's considered a higher.
You know, there's a twist to this. Some carriers do not, pay if a psychiatrist uses a G code. Remember, encephalopathy is a G code. So it's a smarter way to do it. And also, if you put only F05, they are looking for another code as an etiology. So smarter way will be to put both the codes, F05 and then G, whatever it is for encephalopathy.
So actually, I guess it's like I'm one of those where I'm just kind of covering all the bases, but so in the note, it's like one of the things that I'm just always drilling with the team is like, don't just say delirium, don't just say encephalopathy. Why? Like, what's going on? So it's like, so I literally at this point, I'll like in the addendum, right? Like, delirium, also known, also known as, or like / encephalopathy due to, or most likely due to whatever's going on, right? And discuss the behavioral like manifestations of it. Half of that is trying to, educate the primary teams, and half of that is like trying to also model for the residents. And then the last part is just like trying to not have my note kicked back at me, from the from billing. Right. So
I'm just wondering whether, Patrick, whether you want to, I think you gave us some examples that you wanted to use. Did you want to give your
oh yeah. Ooh, we are 5:10.
I actually went through them. People have done that, but yeah. Oh, okay. Well, I guess we'll have people who made the case kind of explain why they.
And please, everyone, we are at 5:10, so please feel free to go do whatever you need to. I have no idea.
5:15 is the poster session.
There you go.
All right. All right. So the first question in terms of the patient with the consult with a new consult for major depressive disorder, the level of medical decision making would be. What's your question?
It'd be moderate because you have a new problem and you're prescribed medication.
All right. So then we have this this teaching case with a case of withdrawal delirium or encephalopathy, right? And we have a various number of minutes here with attending resident and the medical student. All right. What was your answer?
This is mine. So you basically, this is a bit of a kind of a trick question because you have attending resident. So if you look at it, the attending review the chart, 5 minutes. You look at number 2 with the resident, you ignore that. And then the attending spoke with the primary, with nursing and primary medicine attending, right? So that's actually, attending time. So that counts. So that's 5 + 5. And then this issue about the next one, attending discussion with the resident medical student regarding plan. That's kind of one of those things that we were talking about. It's sort of unclear. The attending has general teaching to resident. That certainly will not count. The attending documentation, 5 minutes, that certainly counts. So you would add 5 plus the 5, that's 10. The other one, it would be, the specific plan, you could probably add that. So it becomes 15, right? And then I think the attending documentation, it becomes 20 minutes. I think, am I adding correctly now? Yeah, 20 minutes. So again, we were talking about the time spent, how everything has now changed. So that's actually not a whole lot of time now. So I believe for a 99233, it's 50 minutes. And I believe, and again, I think for 232, is it
35?
35 now.
Yeah.
So you actually don't even meet that.
So you would bill on complexity, maybe?
Yes. So this one I would not bill as time. I would do it as medical decision making, right? Because this is now a pretty ill patient. Yeah. So I would not bill on time.
All right. So this one is
This one's mine.
this is patient for suicidal ideation, 75 minutes in time, all in. All right. And it's choose the most appropriate guideline per CMS.
So if we're doing based on CMS guidelines, it has to be one of the Gs. So it can't be the 99418. So these two are kind of gone. So we have 75 minutes. where are we? And so so the 75 minutes, so suicidal ideation, that's going to be you're already meeting criteria for the 99233. So then 75 minutes, that's over, hold on a second.
50.
It's 50 to 75. And so you've met for the one unit of the G0136 code. So here we are.
Okay. So here's a patient that's it's an outpatient, say in like an oncology, like a CL clinic for outpatient oncology, that are doing well vis-a-vis their cancer, they're for depression, things. This is actually based on a case that was sent into the APA. But I made it more kind of CL. They're doing well for they're getting SSR for depression and anxiety. You're spending 45 minutes in total. You're reviewing the charts of the oncology notes, and you spend 20 minutes of that in preferring the supportive psychotherapy. Okay. So this is interesting what people said for here. One can make an argument for any four of these answers. All right. What the first thing, we look at 215, if someone decided to say, okay, 45 minutes in total time, ignoring the fact you did psychotherapy, that's 215. That's enough time for 215. But the fact is you did do psychotherapy, so you shouldn't do that. All right. So so if in fact you did psychotherapy, you should bill for the psychotherapy time. So that should be something with the 90833 code. All right. So the way this kind of came up with an APA, someone sent this in because if you look at it, they're being treated with medication, right, which puts them into a moderate category, right? And I think the intention was they were trying to say that they had two stable chronic illnesses, which would also put them in the moderate category, which would make it 99214 plus 90833. And I think the questioner was saying that doesn't seem right. The patient is stable, they're on medication, all right, they're doing well. But you have two diagnoses, two medications, that makes it 99214, which seems wrong. And one way we handled it is like, well, if it was depression and alcohol abuse, depression and ADHD, it's clear you're treating two separate conditions. So we said, look, we actually don't have enough information. If you're saying, okay, the patient has panic attacks and we're addressing that separately, but you really have to be showing that you're treating two separate conditions. Depression and anxiety go together, so probably that's safer as 99213. But when I first made this calculator, though, one of our colleagues at the APA made sure to put a disclaimer saying that even though you meet criteria, it depends on medical necessity. So let's say, okay, we're not saying depression, anxiety, it's depression. That's 99213. We didn't, this was vague here. But if you were seeing the patient every week, all right, there's an argument that a 99213 isn't even justified every week. All right. And so some people would recommend 99212, not as an undercode, because that if you weren't seeing the patient every week, you would not be doing that high level E&M code every week. And that's a little bit controversial because by the books, it should be 99213. It's just that there are payers that will turn that around and say it's not medically necessary to do 213. So,
I think this example speaks well to the psycho-oncology example, that question that came up earlier about you're seeing a patient, undergoing cancer treatment and then also doing some concurrent, psychotherapy. So I think that's a good example.
I actually think 3 is. 3 is, again, it was purposely vague. I think if you were seeing the patient every week, then it would be 2. But I think by the numbers, I think 3 is actually the most appropriate, unless the anxiety, unless there was something else, or you're clearly treating 2 separate conditions.
And I think one thing too, that's like, all of our goals was to help increase everyone's comfort and kind of thinking, kind of the ballpark of where you're landing, and then and being able to then use these calculators, use these cheat sheets to fine tune or to kind of check like, well, was it 2 or 3, right? And kind of check that, but to kind of get more of that ballpark feel. And then also like, I will speak for myself, but for myself, I find it easier just to try. I don't try to over optimize, because like I literally just would never get anything done and never finish my notes, right? And it's just more like knowing I'm pretty solid most of the time and getting through my notes and billing faster, um, you know, uh, as opposed to getting it absolutely optimal and perfect every time.
I think that's a really important thing, is because some people have said, well, I want to maximize this. Every patient I see is a level 3 highest complexity. And if you do it every time on every note, I think that's going to be a problem, because again, if you look at the APA, there's some, there's national numbers of what psychiatrists bill for. If you fall, it's sort of like paying your taxes. If you fall within the sort of the range, you're going to be fine. But if you're paying no taxes, well, you're going to get a red flag. And same with this thing. I think if you're calling everything at level 3 and you're doing, intensive psychotherapy every day with your patients, that's probably going to get audited.
Yeah. Thank you, everyone.
Yeah, thanks.
Thank you.